Welcome to The Virtual Shift, a show looking at the seismic changes happening in healthcare with virtual care at the epicenter. Join me and my guests as we look at key cultural and policy shifts impacting how providers, payers, and patients connect, as well as how care is being reimagined both for today and the future. Hello, and thanks for tuning in today. I'm your host, Tom Foley. You can learn more about this show by visiting the program on healthcarenowradio.com, and be sure to follow me on LinkedIn, Twitter at FoleyTom, and the hashtag The Virtual Shift. And we have a great guest on today, Tommy Ibrahim, MD. He is the president and CEO of Bassett Healthcare Network. Tommy, welcome to the program.
So glad to be here, Tom. Thanks for the opportunity.
Awesome. I am very excited about speaking to you. You have some very interesting perspectives relative to Bassett Healthcare, care in the rural setting, as well as fee-for-service versus value-based care. And hopefully we'll get to all those points in this conversation. So before we kicking off the conversation, why don't you tell us a little bit about yourself and Bassett Healthcare?
Yeah, no, thanks, Tom. So as you mentioned, I'm a physician by background, internal medicine trained. I grew up on the East Coast, trained in Baltimore, Maryland, practiced as an internist and hospitalist for many years, got tugged into leadership somewhere along the way there. I oftenly joke and say out of frustration. I would always run into issues getting in the way of ideal patient care and would figure out how to fix that. And before I knew it, I was getting pulled into larger roles. Ultimately, went into much larger and successively accelerating physician executive roles, and ultimately landing here at Bassett as the CEO. Bassett's a wonderful, wonderful organization. It's been around for over 100 years. We're located in central New York. Our flagship hospital, Bassett Medical Center, is based out of Cooperstown, New York, which is the baseball epicenter of the world. And we are a large integrated rural healthcare delivery system with about 5 different hospitals across the central New York region. We span 5,600 square miles. We offer all of a number of advanced clinical capabilities, as well as a full care continuum operation, a fully employed medical group, a wonderful backbone in academics and research that dates back many decades, and an incredible partnership with Columbia University out of Manhattan, where we co-operate a medical school program, among many other things. So all in all, a fantastic organization with a fantastic future.
Well, what compelled me was your focus, as I was saying in the opening, of fee-for-service to value-based care. So let's talk a little bit about that first, and then we'll get into how that might apply and the challenges you might have in doing that in the rural setting. So this is the biggest challenge, right? Everybody typically is in a fee-for-service model. We're trying to get over to value. I personally don't believe that there's been an established pathway to show physicians how to get there. So they continue to run, as I always say, and I hope you don't take offense to it, but they continue to run on the hamster wheel because they don't have any other way. And if they need to make more money, they run faster on the hamster wheel as opposed to really trying to do what they want to do. And one of the things in your article that I had read, physicians are just trying to keep their head above water. Right, to step off and to be strategic and to look at how to apply value-based care without losing the business that they're in is a very challenging aspect of the model. So tell us a little bit about your thoughts on fee-for-service and why the need to move to value-based care.
Yeah, Tom, I mean, I think you touched on it really well. I mean, the model sort of historically has been the fee-for-service model. It's what, I trained within. It's what most physicians know best. And it's what we've sort of been accustomed to. The incentives are such where it does pay more to do more. And, that often contributes to an excessive amount of utilization, often unnecessarily. It contributes to, an excessive amount of waste in the organization. And it's sort of, one of the main and predominant reasons why healthcare is 18% of the GDP. We all know that that's not sustainable anymore. We all know that we need to, make adjustments. But that transition is very, very difficult. The incentives are not aligned. As I mentioned in my Health Leaders Media article, right now, it's incredibly challenging for organizations like Bassett and the many other organizations across the country, particularly in rural healthcare, to make that leap, just because of the financial straits that we are often finding ourselves in. I mean, if you look across the country, over 50% of hospitals are just narrowly making any kind of margin, and the other 50% are losing money, and significantly so. The incentives are just not aligned. We don't have I think, the reserves to invest in the necessary infrastructure, the capabilities around analytics that are required to make that transition, the infrastructure that's required around case management and patient navigation. All of those really, to be successful in a value-based model, require investment and resources, most of which organizations like ourselves just don't have the capacity to take on at this point in time. So there's a significant challenge that I think requires both state and federal legislators, it requires community organizations and healthcare leaders to really come together to try to address here once and for all. But it's not going to be easy.
Yeah. I hear you. What role do you think the consumer has? Now, I know you have a unique situation. You're in a rural setting, so it's not as if I can hop in a car and drive 2 minutes to my doctor's office. It's typically it's an hour or two, and that creates the greater challenge, right? And sometimes coming into town, if you will, through an hour and a half ride, it's quite expensive, and it's a 15-minute event, and then I'm driving another hour and a half back home, right? So, but what responsibilities do you think payers and providers have, and even patients have, in the move to value-based care?
I mean, I think it has to be a partnership. I think the sort of the paradigm of payers and providers sort of rustling at the table around fees and sort of negotiated rates and things along those lines is really way of the past. And the more that we could collaborate, particularly if we're of the same mindset to move in a value-based direction, I think the better it is for everybody, including patients, of course. I believe payers are very motivated to have this conversation. Obviously, it serves their agenda well, as it does for value-based providers like ourselves. And I would also go as far to say that I think rural geographies and demographics actually create a wonderful sort of place to start in terms of driving a value-based agenda. I mean, if you look at the region that we care for, it's a pretty well-defined region. It's large, 5,600 square miles, but it is pretty well-defined. Across that geography, Bassett Healthcare Network is, one of the sole providers in that space with a very, strong relationship and deep loyalty, bidirectionally with our communities. And it is elderly, right? It is sort of a frail and very dispersed, region that is often challenged from a recruitment perspective, often challenged from other resource perspectives, and again, sort of serves as a wonderful incubator, if you will, to really begin driving this notion of value-based care and this proposition of doing more with less. Really focusing on, creating value, really focusing on health and wellness, focusing on prevention, focusing on, reducing utilization, which is already sort of happening by necessity, quite frankly, because we just don't have the necessary manpower or the resources or the infrastructure to support, all of the sort of acute sick care needs that the community might need. So why don't we make the shift? Right? Why don't we move more quickly to really supporting health and wellness and prevention?
To some degree, I think a path, if I might take the opposite view, I think that there is a path defined. I just don't think it's promoted correctly. And so hear me out for a couple seconds. So the average Medicare my audience knows these stats. They know where I'm going. The average Medicare patient, not 5 chronic conditions, sees 9 different doctors. By CMS stats, they're only in front of their doctor 15 hours in a given year. The question, and to me, the way Tom Foley defines the care gap, is what happens the other 8,745 hours? That really is where the value is missed, in that it's that lack of engagement. I give you I went through the trouble of actually getting diagnosed, having the exams, being diagnosed, getting the scripts, getting my care plan. I go home and I continue to eat that fried chicken, right? or some other junk food that is not as healthy as other foods, right? So, and you should know that my father was obese, so I speak from actually true experience about this. So, but the point is that it's only when what it's not, and I always take the cases. It's not so important as to what happens when you're in front of the doctor. It's what happens when you're not in front of the doctor that really it tells whether or not you are on this continuum from awareness. I've just been notified I have diabetes to a greater state of wellness, right? So, so the point there being is, how do we close that gap, right? In a fee for service model, I would argue certainly telehealth, remote patient monitoring, chronic care management are all fee for service oriented, right? But at the end of the day, when you deploy that, while a physician might not be interested in whether or not they reduce the emergency room visits or hospitalizations because they don't get paid on that anyway, right? At least a primary care and internalist wouldn't. But it shows what they can do with a virtual program. What are your thoughts on that?
Yeah, I mean, I think you're spot on, Tom, and thanks for sharing some of those stats. I learned a few things from your comments. And this is not uncharted territory, right? I mean, there's a lot of organizations that have already figured this out. I mean, I just think about some of the other vertically integrated healthcare systems out there, like Geisinger and Intermountain. These payvider institutions that have created health plans and learned how to really manage risk well do this extraordinarily well, right? So you sort of create this ecosystem around the patient that does exactly what you mentioned here, Tom, is sort of create a care delivery model that engages patients throughout the year, not just sort of in an episodic fashion, right? So, patient navigation becomes critically important in that, making sure that there's, a wraparound of technology, sort of automated reminders, education, ways to check in on patients remotely through remote patient monitoring. I mean, there's so many new technologies and tools that are at our disposal now, particularly throughout the pandemic. We've seen an incredible explosion of digital health and innovation within the industry, to do this very thing, right, is to sort of create this catalyst to drive value-based care and to support the holistic needs of patients. So it is absolutely doable. Organizations are doing it every day and doing it remarkably successfully, and we just need to model after those and not reinvent the wheel.
No, I agree. And so, and that's why I asked the question earlier about, what responsibility does a patient have, right? The sole responsibility of value doesn't rely on the physician, at least in my opinion. And when an organization, the greatest leaders in the world will tell you an organization operates best when there's alignment, right? When I go to holiday family outings and sit down at the dinner table with friends and things of that nature, I ask them, do they even know what value-based care is? And no one knows, right? So the point is that in a value-based care system, I have greater responsibility. I might also say accountability to reduce my A1C, right? To go on a diet and lose weight, to exercise, right? That's the prescription. It doesn't always have to be a drug. The point there being is, I think that the health system is lacking alignment between what happens inside the walls, the brick and mortar of healthcare, versus what happens inside the walls of a home. And so they walk away with that script and they say, I don't want to take that script, right? So the doctor is out on the limb here because the doctor is in a value-based care model and they get paid on outcomes, right, for the most part. So I just think that there's how would you suggest we better align the ecosystem, if you will, or patients with the understanding of, hey, you're operating within a value-based care model here, and this is what our expectations are.
Yeah, I think it's a fantastic question, Tom. I mean, I just sort of think about, just even beyond healthcare, just think about I think about myself actually, right? Trying to stay motivated just to work out or eat healthy, or we all get weak, right? And we're sort of in a flurry every single day that we often prioritize things that are more immediate or urgent, and deprioritize everything else, right? And I would imagine, that is a large problem, right, within healthcare and patients taking care of their health. We often deal with noncompliance and medication non-adherence and all of these other things. But I think the large majority of people, we're going to have your recalcitrant folks that are going to be immobile, right? You're not going to be able to move them regardless of what you do. But I think the large majority of patients, if they had the proper coaching, if they had the proper support systems, if they had the appropriate structures in place, they would really, sort of keep the momentum and maintain motivation to do what's best. I think that's where we come in, right? That's where, as a healthcare provider, we sort of pride ourselves in being the most trusted healthcare provider for our communities. If we can foster that relationship and build that ecosystem around the patients, I think the vast majority will come along. We're not going to get everybody, but the vast majority, I think, will come along.
Yeah, I agree. So, we talked a little bit about emerging technologies and some tools that could be put into the hands of patients and even the provider to leverage. Where do you see the convergence of your challenge in rural healthcare with the adoption of emerging technologies to advance your cause?
Look, my thesis is that rural healthcare is going to become dependent on innovation and technology. I mean, that is my thesis. I believe it is going to be the single most important lifeline for rural healthcare for various different reasons, right? I mean, if you just look at the number of challenges that we're up against, I mean, again, elderly, frail population, major social determinants that are very difficult to address, like transportation and broadband access, food poverty, energy inefficiency. I mean, you name it. It's a very challenged demographic. And we were having a hard time staffing our facilities, prior to the pandemic. Post-pandemic, workforce staffing in rural healthcare has just been completely decimated. Hard to recruit people to rural, hard to keep them there. There are housing shortages. There are, again, transportation challenges, and there's resource issues, within rural environments that make it hard for particularly younger families, with children to, move to the region. So all of those complexities really create for a major scarcity, that I think often feeds a vicious cycle within rural healthcare. So I believe that we have to fundamentally reinvent the care delivery model. I believe it is absolutely going to become dependent on virtual capabilities. We're driving today at Bassett a virtual nursing program. We're driving virtual ICU programs. We're looking at rolling out a virtual first model, which would essentially, segregate all of the lower acuity type visits to more of a virtual, platform, and free up our physicians on the ground and our APCs on the ground to see the more complex cases that are, requiring sort of that face-to-face interaction. And I think, that is going to continue to grow and spur. And I think particularly as we continue to drive this value-based agenda, looking to other partners that's, in this new innovation ecosystem that's been created is going to be absolutely essential. So I don't see a future in rural healthcare without digital, without innovation.
And oftentimes you talk about digital and the demographics of the population being elderly. The two often, at least in my opinion, you often hear that they don't match well, right? Older people typically don't use technology. How do you solve that problem?
Yeah, we studied that, across central New York, and I was really actually pleasantly surprised at how, that perception was not true. We do have broadband issues. There's no question. About 17% of our population has limited or no access to, strong connectivity, internet connectivity, there's no question that. I think an elderly population is a little bit, less digitally savvy. We were very surprised to also learn that, if you look at our Epic platform, for example, My Epic, which is the sort of the online portal for our patients, we actually have over 65% registration. So that means, over 65% of our community is on that portal, which means they're actively, going online and scheduling their appointments. They're looking at their medical records. They're sending emails to their physicians and actively engaging through an electronic means, which is staggering. And if you look at across all of the Epic shops across the country, we're way above the bar in terms of the utilization and the engagement across Epic. So that was a very, I think, striking and pleasant surprise to all of us. So I guess my point is, I think that is there's some truth to what you're saying about kind of an elderly population maybe disinclined to engage through technological means. But I think more and more we're seeing a growing trend where that is starting to catch up in a very positive way.
Yeah, I actually tend to agree with you. I used to be a patient portal product manager in two different EHR efforts, and currently very involved in apps in the same light. But I have an 84-year-old mother-in-law who has a smartphone in her hand all the time, right?
Yeah.
So I always try and challenge the person that says an elderly person won't use it because I just have a different experience. So I'm glad you're one of the few that actually have reinforced that. So I appreciate that. I might borrow this sound clip. And no, I'm just joking.
That's all right.
But so we have a couple minutes left. We have this convergence of technology. What do you think that local, state, and federal government needs to do differently in order to address these problems?
I think it has to be all hands on deck. I think we're really at an inflection point right now in healthcare. Obviously, what we've been going through as an industry for the past few years has really precipitated an acute crisis. Quite frankly, just as an example, there's over 600 rural hospitals across the country that are at risk of closure. That's a staggering number, and for rural in particular, most of those hospitals are usually the largest economic drivers for those communities. They're the largest employer. Not to mention obviously the single source of healthcare services. So, beyond rural, I think most of healthcare is feeling an intense pinch right now with the economic challenges that we're dealing with, the workforce-related challenges, et cetera. I don't see a future, quite frankly, without heavy government intervention. And I think government has to play a role in sort of addressing the current economic crisis that we all are experiencing. I think government has to definitely play a role in partnership with employers and other community partners to really drive a value-based agenda moving forward, and to ensure the viability of healthcare services and access, quite frankly, for patients. Otherwise, I fear it is going to really affect patient outcomes long term, and we're starting to see that unfortunately play out now, across the country. So I believe this is the time for, state and federal, legislators, organizations like, the American Hospital Association, other advocacy organizations to really come together with payers, with providers, to try to figure out how to solve this once and for all. Otherwise, we're going to continue to spiral, and our costs will continue to go out of control and put further risk and pressure on the entire system.
Yeah. I'm going to stray for a second. We're both from Jersey, so I was on the Board of Education for a long time. I was the Monmouth County legislative representative, and at the time, the governor had there was new legislation where it would fund reconstruction of schools. So we're in a new school, an urban school district, and brand new school building. And the state legislator said to me at the ceremony, he says, "It's not going to make a difference, right? We invested this. The building looks nice, but but these kids are going to come from a broken home, spend 5 hours in a building, and go back to that broken home. The cycle of so the point there being is education wasn't about the brick and mortar. The education was actually what took place and what did the child learn, and you have to, and it's a 24-hour process, if you will, not a 5-hour event, right? So the same thing holds true in healthcare, is that redoing something inside the brick and mortar or even extensions into the home is helpful, but there's a larger ecosystem, and that's where this other factors come into play. What surprises me most is that with all due respect, the dysfunction in healthcare today, the need for investment today, I haven't heard one politician, if you will, running for president across the board talk about healthcare. It's not on the agenda, and then that is what's so surprising. I don't mean to turn this into a political discussion, not at all, but it is interesting that as much as we need a transformation, the leadership from the top, whether current or future, needs to be part of that cheerleading squad that says this is what we're going to do, bipartisan. This is what we're going to do, right? Thoughts on that? Without getting, not wanting to get political, but just overall relative to an agenda.
I don't pretend, to know how to fix this at the sort of the governmental level. It is extremely, extremely complex. All that I know is that we all have to come together and educate and help our lawmakers really understand some of the challenges that we're facing and what it really means for patients. In my discussions with lawmakers at both the state and federal level, I think all of them are really well intentioned, but I do think that there's a fundamental misunderstanding of the reality on the ground, and I really think that contributes to a lot of the churn and the spin that we often deal with.
I would agree. I absolutely agree with this is all one country. We're all on the same team, as I say. So we all have to come together and fix it. So with that, we'll close there. Tommy, I truly appreciate you coming on the program, sharing your views, sharing your thoughts about where we need to go. You're always welcome to come back onto the program. Thank you very much.
Thanks for having me, Tom. This was fun. Take care.
That's today's shift. I appreciate the audience taking the time to tune in. If you missed part of today's episode, you can tune back in at the healthcarenowradio.com at the same time, 11 a.m. or 7 p.m. Eastern throughout the week. And be sure to check out the program page at thevirtualshift.co. As well, remember to follow me on LinkedIn, Twitter at FoleyTom, and follow the show's hashtag, TheVirtualShift. I'm Tom Foley. Until the next shift.